Okay, yeah, you can start now, yeah.
Okay, good evening, good afternoon, good morning to all our colleagues, actually, wherever you are in whichever part of the world. Thank you very much for joining us today. I have got two really dear colleagues of mine, actually, from DOW 2002 who are going to be presenting today. We have got our chair of the DOW 2002 webinar, Professor, I should call him, Naseem Naqvi, actually will be presenting, will be going first. He's our eminent stroke physician in the northwest of England, and he'll be talking about a case that has changed his practice. So Naseem, I know you would like to go first, and then we've got another prominent colleagues of our batch 2002, Dr. Saqib Ghani, will be talking about COVID and its effect on the heart. So Naseem, I would like you to go first. Your time starts now. You've got 20 minutes, and then if you could actually mute all the other participants. Thank you.
Yeah, thank you very much, Sue. I've got quite a few cases, not one case, a few cases that I have seen personally under my care, and which I thought were very interesting. So let us go through them quickly. So as you explained in the beginning, I'm a tele-stroke physician. So when I'm on call from home, and I'm covering the whole of Cumbria and Lancashire region, which area in terms of catchment. So my on-call starts from 5 p.m. and end 8 a.m. the following day. So I'm on call overnight. So these patients that I'm going to discuss all presented out of hours. And when you see these cases, you will realize that there are sometimes can be very challenging in terms of management, but nonetheless, very interesting cases. So normally I keep it interactive, but I think people are muted. So I'll just ask a question to, generate some interest, and then I just give answers myself. So this patient was a 21-year-old patient, was referred to us with sudden onset of right-sided weakness and dysphagia. NIHSS score, which is a scoring system we use to assess severity of acute stroke. It's called National Institute of Health Stroke Score, and it ranges from 0 to 40. And basically, the idea is that lower the score, the lower the severity of stroke, the higher the score, the higher the disability and weakness. So 111 is quite large for a young guy. So we did a scan, and this is brain scan. It's a normal scan actually, and normal for a 21-year-old. Bleed, can't see anything. Bleed looks white on CT. So these two white structures that you're seeing are actually arachnoid granulations in the ventricle region, and nothing else. So the question is, would you thrombolize? Would you thrombolize or not thrombolize? There are three challenges when we are faced with acute stroke type scenario. One is that is this a stroke, first of all, or is it a stroke mimic? So there are many conditions that can mimic a stroke type symptoms, as we all know, hypoglycemia, seizures, and so on. And the next important question is, if this stroke, then is it a bleed or is it a clot, ischemia? So if it's ischemia, you are fine. If it's bleed, you're in big trouble. And if it's a stroke mimic, well, all of us have thrombolized stroke mimics. So sometimes it's difficult, really. When I was presented this case, I thought there is no contraindication thrombolysis. So we thrombolized him. His symptoms partially resolved. Next day's NIS score was 6. It came down, still had some weakness. And just when we were about to do some more investigations like MRI, angiograms, echoes, his mother came to the ward and told us that he is actually been using lots of drugs, including cocaine. So this guy actually had a cocaine-induced stroke, and cocaine causes severe vasospasm, as we know. If I had this information, had I known this, I would have given him GTN rather than thrombolysis. But anyways, he was thrombolized, he partially improved. So learning point, young patient, drug history, very, very important. Sometimes they don't tell you. Next patient is, I saw in August 8 years ago, out of our call, again, elderly lady, abrupt onset of aphasia. This is her scan. So you can see it looks a bit different from the previous scan, but because she's 84, so as you grow old, your atrophies, there is more CSF in the brain than the gray matter. So the lot of black that you are seeing is actually just CSF and cerebral atrophy. So it looks fine. There's no bleed. Radiologist reported a small vessel disease. So acute ischemic stroke, we thrombolized. She recovered very quickly. Carotid Dopplers were normal. We started on antiplatelets, statins, and discharged. 3 months later, she presented again with similar episodes, and this time they were very, very brief. And she referred to my TIA clinic. And her husband was with her, and what he described was very repetitive gulping episode. Like she's like repeatedly swallowing. It's very strange. There's nothing in her mouth and happens quite frequently. So we thought that given the stereotype nature and recurrent nature, automatism, this is very classical of seizure disorder. So we started her on anti-epileptic, and we have not seen her since then. And she's doing absolutely fine. So it looked like what she had was Todd's paresis. Sometimes can be difficult to distinguish from stroke. And the interesting thing was there is no history of epilepsy. It can be difficult. And seizure we know is a stroke mimic. The key thing is that these are recurrent attacks, stereotyped events. This description is very important and all based on history. Case 3, 32-year-old male, sudden onset of left side weakness, dysphagia, left neck. NIHS is high, blood pressure normal, smoker. Would you thrombolize? CT scan normal, no bleed. So we thrombolized him. NIHSS quickly came down to almost 0, and he had no symptoms. Now this chap, he self-discharged himself against medical advice. Immediately the following, and he said, "I'm not staying and I'm going home." And he had capacity. He went. Over the next 8 months, he presented at 4 different hospitals in the region, and we know he presented at 4 different hospitals because we have our audit, telestroke audit meetings. So we discussed this case, and we thought, okay, hang on, what's going on? This is a young guy. He's presented 4 different hospitals with similar symptoms, and he never stayed. His symptoms just improve, and he just self-discharged himself. All of his scans have always come back normal. So it turned out this guy has a syndrome. He just brings his symptoms on himself. And the difficulty with stroke is that if somebody is telling you, I've got a lot of weakness, sudden onset, to believe them, especially if it's out of hours and you are on the other end of the computer discussing. There is a doctor in A&E telling you, I've got a patient weakness. If they are telling you they are weak, they are weak. Difficult to challenge them, and especially if there is a classical stroke type history. And always another consideration sometimes, these cases we see as well. Another case of 80-year-old rheumatoid TIAs, sudden onset of left upper limb weakness. She said that she was holding a cup and it her left hand, and she has difficulty holding a pen with the left hand. Husband just described as having his foot in her hand, but she said that she was having some difficulty in holding the stuff. So when we examined her, there was some mild, well-preserved power and no visual field loss. ECG was fine. So I thought this right-sided weakness in a middle-aged lady could be right-sided infarct. So we ordered a CT scan, and she had a transient left hemiparesis while waiting for carotid Dopplers in the waiting area. And this is her scan. As you can see, there's an abnormality on the right side, a large hypodensity. This hypodensity is basically old bleed. This is subdural, very classical. And actually there is another small one on the left side. If you can see on the screen, it's difficult to appreciate there. So basically she had bilateral So we did an MRI scan, it's very clear on MR. Bilateral.
Sorry, could you please mute your audio? Sorry, whoever's
Hang
actually.
on, I'll mute them all. I'll mute them. Yeah. Okay. Can you hear me, Mansoor? Yeah. Okay. So basically, there was a history of trauma. She bumped her head. Some traumas are very common in elderly, sometimes underdiagnosed. Trauma, usually there's a history of trauma and due to delayed onset of symptoms, usually days after, sometimes few weeks or even months. Can be insidious. There is fluctuating level of consciousness, fluctuating symptoms, fluctuating features, ataxias, and so on. Next case is a 44-year-old woman, clumsy right hand, worsening weakness. And the story was quite interesting that she had, so the symptoms started at 9 o'clock, and an hour later, she was unable to lift the wrist against gravity. And another hour later, she was unable to lift the arm against gravity. So it started in the hand as a clumsy hand, then wrist got weak, and the arm got weak. No change in sensations. And she described a similar episode 4 months prior to this. He got worried, he called 999. I was called at past midnight to assess this lady. Past medical history was anxiety, depression, mild asthma. She was a smoker. So I assessed this patient with the SPR in Carlisle at the other end, and she was a bit hypertensive. Right arm was weak, right leg was much weaker, pyramidal pattern of weakness, right upgoing flutter, hyperreflexia. So we did a CT. Now, if you look at the CT, especially the mid slices, it actually looks normal. Okay. But as you come up, you see this very small, I don't know if you can see on your screens, on the middle image, the bottom on the right side of your screen, which is the left side of the patient's brain. You see this small area which is like a crescentic shape. And I was not sure what it was. So we decided not to thrombolize her. I said, I'm not too sure what is this actually. It's a bit odd. This is a zoom in picture of that. Anyways, we admitted the patient. We said we are not going to thrombolize, but we'll do an MRI scan in the morning. And this is the MRI scan, and that lesion is hyper intense, very bright. It's there. So we thought, okay, this is interesting. What is it? So we discussed with neurologists, and they said, do a CSF. This could be demyelination, a patch, because she's young, and the symptoms that she had was not like all came at the same time. They came on like gradually. An hour, arm got weak, and then the leg got weak, and so on. So history very important. So she had oligochondral bands positive, very high protein CSF. So basically, she had demyelination. She was started on steroids IV, and she got a bit better. Another case, 43-year-old lady, resting, sitting with her arm back of sofa. Left hand suddenly dropped. Fingers went dead. She went to a GP. GP referred her to clinic. 2014 it was. And the referral said left radial nerve palsy. Is this left radial nerve? Poor TIA as well. I'm not too sure. Please advise. We did an outpatient MRI. It was reported as normal, but on examination she had some weakness in the finger, sparing of the thumb, but the arm was weak, but there was thumb sparing. If you remember from your neurology, neuroanatomy, if you have a radial nerve problem, the thumb area is almost always involved. So this is a bit interesting because it doesn't really fit in, because the thumb itself was fine, that it is the up. So we discussed this case. So we did further investigations. Bubble was positive. We did a TOE, referred for endovascular closure. Reviewed an MRI scan again to see if there was anything. And if you look at the MRI, there is a small area of hyperintensity here, which corresponds with the hand and the arm area in the brain, in the cortical region. So we thought, okay, maybe she had a very, very small embolic stroke, which was initially, the scan was reported as normal. This is another case, telestroke on call. This is Christmas. I was on call, and early hours of the morning, got a call. 49-year-old man, sudden onset of dizziness, left-sided numbness. He had his Christmas turkey in the evening. He was with the family, and whilst he was eating, he vomited, sudden vomiting, and he became a bit slurred in his speech. He became ataxic, diplegic, couldn't swallow, and the left arm and the right side of his face went numb. Immediate CT scan in the AE department showed, as you can see, there is a hypodensity here in the cerebellum, cerebellar region. MRI scan also showed a problem. And so when you come across with this story with ipsilateral cerebellar signs, lower cranial nerves on the same side, Horner syndrome, and contralateral spinothalamic signs, pain and temperature, crossed signs, this is usually what we call Wallenburg syndrome or lateral medullary syndrome. And lateral medullary syndrome is, if you remember from your neuroanatomy, is basically a problem in the posterior inferior cerebellar artery, pica syndrome, because it supplies the part of the cerebellum and the brain stem. So all the lower kind of nuclears are involved, and why you see cerebellar dysarthria, dysphagia, and so on. Last case is a cleaner at the hospital, our hospital, Blackpool, 57-year-old lady, very nice, we know her, she worked on the ward, and she had a background of migraine, hypertension. Whilst at work in hospital, she developed sudden onset of dizziness and feeling very, that she was like about to fall. And she actually passed out for a few seconds, no clear description, she was on her own at that time, and she was taken to A&E. By the time she reached there, her symptoms were much better. She said, I'm okay now. And she diagnosed her with TIA. 2 days later, she complained of headache, which was pretty bad. And she went to see a GP. GP said, oh, you've already had seen the doctors there. They gave it, this was a TIA. So just take some, analgesia. So gave her some paracetamol. She was not getting better. 4 days later, she saw the GP again. And this time she said, my headache is actually getting worse and worse, and photophobia and vomiting. He said, okay, this could be migraine because you already had migraines in the past. But she was very anxious. So GP decided to admit her to the hospital, and she had 8 out of 10 headache when she came in. CT was done, which was normal. Lumbar puncture was normal. So they discharged her with diagnosis of CT normal, LP normal, could be tension headache, could be migraine. This is her CT brain, looks okay. But she remained mostly bedbound, and every time she stands up, she felt dizzy. And 2 days later, she presented again to hospital with transient loss of consciousness, this time with a visual loss, right arm weakness, right leg weakness. So, and then telestroke was called. She had a GCS, normal visual fields, but slightly increased tone in the left arm and left leg. Power was 1 out of 5 on the left side. She couldn't lift the leg. Left leg was completely dead. Brisk reflexes. Fundoscopy showed papilledema. And this is a CT brain. As you can see, even those of you who don't see CT scan brains on a daily basis, you can see that this is actually a very, very abnormal scan. The two very important and very obvious abnormalities of this bleed, white thing in the left parietal region, and also there is something in the right left frontal region as well, right parietal. So she had 2 intracranial hemorrhages. One was kind of subacute, and the other was very acute. So what is the diagnosis? If you see something like this, the first thing you think of is venous sinus thrombosis. Venous sinus thrombosis is a condition where you see lesions in different territories of the brain. sometimes unexplained hemorrhages, unexplained infarcts, and don't fit into any arterial territorial territory infarcts. So we discussed with the regional center, they said heparonize and give her some capra dexamethasone. She recovered, slow, anticoagulated for 6 months. She's back to work, and she's been doing well since then. So one of the learning points from this was that we should have checked her opening pressure, etc., when we did the first LP, and also looked for papillary edema, because sometimes you see this finding in venous sinus thrombosis. So some
Naseem, what was the cause?
Stroke can be cardioembolic.
What was the cause of this venous sinus thrombosis?
Find any cause in her case. Sometimes you don't find. Sometimes patients are on things like contraceptives, dehydration, sepsis, and so on. But in her case, we couldn't find any cause. So strokes mimics. Brain imaging is not always the answer. Always think of stroke mimics, and stroke is a clinical diagnosis supported by brain imaging, but brain imaging can be normal. So that's it from me. If it doesn't fit, review the history, start again. Thank you very much.
Thank you very much, Naseem. I think that was really enlightening. I wouldn't invite any questions at this time because we've got Saqib to present, and I would actually leave any comments for Naseem's presentation towards the end. So without actually wasting any time, Saqib, may I ask you to join in and unmute yourself, or Naseem, could you just unmute Saqib? And Saqib, your time starts now. You've got 20 minutes to present your presentation.
Thank you, Naseem, and thank you, Mansoor. I'm actually envious of Naseem that he does telemedicine and tele-on-call. I wish we cardiologists could do that.
Aren't we all envious?
Maybe at some stage, robotics will kick in. Anyway, I'll try and share my screen. Just bear with me. Host, you have disabled me to share the screen. Can someone please enable me? It's still disabled at my end.
Okay, I'll make you host. Yeah.
Yep, thank you. Can you all see my screen?
Yeah.
Okay, thank you. So I'm Saqib. For most of you know me. You graduated with me, but some have joined from outside our group, which is very reassuring to see. So I'll be talking about COVID-19 and cardiovascular disease and what is it that physicians need to know. I'm not trying to exclude any surgeons here. It's basically an open topic for anyone. I'm mainly based at Down Valley Hospital in Dartford, but I also occasionally work in Basildon, where I initially trained. We will be covering some basic aspects of cardiovascular disease and risks of COVID-19, and touch upon cardiac complications and manifestations of COVID-19, and then how we've tried to deliver services during these challenging times. So just to very briefly, COVID-19 is an infectious disease which was first identified in Wuhan, China. We all know that in December last year, hence the word 19. The WHO named it coronavirus disease 19 in February this year and declared it as a pandemic in March. And as of today, there have been 28.8 million cases worldwide with 3.2% mortality. In UK, the mortality is high at around 11% with 41,000 deaths, but I think the deaths are actually higher. But in Pakistan, just for comparison, the mortality remains relatively low at 2.1% for whatever reasons. Let's hope that continues. The symptoms associated with COVID-19 can be varied, ranging from fever, cough, shortness of breath, fatigue, muscle aches, headaches, loss of taste. And I think by now, the entire world knows because this has been covered in media more than anything else. But it's important to know that it can be difficult to diagnose because of a variety of symptoms. Are cardiac patients vulnerable? Yes, they are. The cardiovascular comorbidities are common in patients with COVID-19. Cardiovascular disease itself is associated with increased mortality in those who pick up COVID-19 infection. And one thing to remember is that cardiovascular disease and COVID-19 and poor prognosis from COVID-19 go hand in hand with age. So maybe it's an age-related factor. What does COVID-19 actually do in the heart? And I've shared this one brief portion of an enormous document that's been published on European Society of Cardiology website to summarize that COVID-19 infection involves binding of the host receptors with ACE inhibitors. And that's how they affect the renin-angiotensin system, which is a fundamental point in this pathway. And that's how they lead to interleukin release, cytokine storm, and then an endothelial dysfunction, which affects all the parts of the body. This picture or cartoon basically tells you how the virus attached to the ACE2 inhibitor and then enters the body and then replicates. But at times it also helps release them. So I'm not going to go into too much detail here in the interest of time, but it just summarizes how the virus actually gets into the body. Cardiovascular involvement. Now this slide looks a bit busy, but you can probably ignore this whole text on the left, which will be difficult to read on a screen. But if you just focus on the right, once the virus enters in the body and starts to invade and replicate, it undergoes a lot of different pathways and affects body in a different way. So it can have a metabolic impact, inflammatory response, and by doing so, it causes myocarditis or damage to the heart, which will lead to troponin rise, as we know, or myocarditis. That will cause damage to the heart and cause arrhythmia, or it can lead to heart failure. At the same time, it's causing macrophages to be released with T cells, causing cytokine storm, which then leads to plaque rupture or instability, causing macrovascular or microvascular dysfunction and acute coronary syndrome. And at the same time, it can affect the heart directly, at the endothelial level and cause microvascular dysfunction, coronary artery spasms or disease. So in a nutshell, what I'm trying to say is it's a multitude of effects, not just one single effect affecting the lungs and the kidneys and the heart. And one thing leads to the other, and the second one leads to number one. It just goes round and round. Prevalence of cardiovascular disease in COVID-19 patients. The initial data from Wuhan showed that 50% of COVID patients had comorbidities and 72% with severe symptoms had more than one comorbidity. Some large studies in China, including 72,000 patients with 44,000 confirmed COVID cases, showed that comorbidities included hypertension in only 13%, diabetes in only 5%, cardiovascular disease only 4%. So this was a surprise. But then the analysts have shown that the detailed analysis showed that the study was lacking in data, and details of comorbidity was missing in half the cases. These are obviously in the initial stages. As time went by, better studies were conducted. For example, in USA, the prevalence of comorbidities was much higher. Hypertension was 56%, obesity 42%, and diabetes 34%. And in UK, a study has shown that cardiovascular disease is present in almost 40% of people affected by COVID. Talking about hypertension and ACE inhibitors, there's a lot under discussion, particularly because hypertension itself is associated with adverse outcomes in COVID. But also, as I will briefly mention, as I've already shown, ACE2 receptors play a fundamental role in viral replication. So although we should be managing per established guidelines, reducing coffee and general lifestyle advice, but there was a hypothesis that ACE inhibitors or use of angiotensin receptor blockers can actually make things worse by helping viral replication. This is only a hypothesis and not proven clinically. And in fact, European Society of Cardiology and American Heart Association both advocate continuation of blood pressure medications, including ACE inhibitors or angiotensin receptor blockers. This is now also endorsed by International Society of Hypertension. So that should rest this case in place. No need to stop these tablets. What should we do with cardiac patients? Well, a lot of them ring us and ask whether they should be shielded. Shielding is a concept where people are advised to stay away from people and stay indoors for maybe a period of 3 months. And for cardiac patients, all those who had transplant or heart failure, cardiomyopathies, ischemic heart disease, congenital heart disease, or particularly pregnant people with heart disease were definitely advised to undergo shielding. What could be the complications and manifestations? One thing to keep in mind is that, as I've shown in the slides before, there's an inflammatory process going on, there's an interleukin release, cytokine storm, effects on the myocardium itself, coronary disease. All of that can lead to increased biomarkers. This disease itself is a thrombogenic phenomenon. We know that there is increased incidence of pulmonary embolism and also acute coronary syndromes in these patients through an inflammatory process. And hence the troponin levels are elevated. If you look on this right, this is a data which shows that raised troponin levels is associated with poor prognostic markers. If for a moment you look at this slide, the red line are the people who did not survive COVID-19 infection, and the blue line are the ones who did. You can very clearly see that within the first 7 days, there's a marked difference between those who had raised troponin levels and not. So these are the troponin levels on the scale. Higher the troponin level, worse the mortality. Similarly, BNP levels are also elevated, but it has not yet shown a direct link with mortality, but I won't be surprised if there is. Talking of cardiac biomarkers, this paper nicely summarizes the various reasons why troponin is elevated in COVID-19 patients, starting from type 1 myocardial infarction. And I'll try and explain, because I appreciate there is some non-cardiology audience here, that type 1 myocardial infarction is because of plaque rupture or the conventional heart attack due to blockage in the artery. But it can also cause type 2 myocardial infarction due to anemia, hypoxia, renal failure, hypertension, and other reasons like pulmonary embolism, Takotsubo cardiomyopathy, and arrhythmias and heart failure. All of that can cause troponin rise. And destabilization of the underlying coronary disease. So some people who may have been stable for months and years can become unstable because of COVID. So just to raise troponin itself does not mean someone has had a heart attack. There could be lots of reasons behind that. More importantly, myocarditis in the current era. If you make a guess, or well, there's no need to, but these trials have shown that approximately 28%, we call it 30% of patients with COVID-19 have elevated troponin levels. Now, if I extrapolate that data, for example, to where I work, approximately 2,000 patients have been in and out of hospital with COVID or suspected COVID. So 30% of that would be 600. That's a huge number. It does not mean that 600 people had a heart attack, but obviously it's challenge and it's difficult to differentiate one from the other. How has COVID-19 affected emergency admissions, including cardiac admissions? In general, we felt that there was reduced admissions to hospital via extended emergency department, and there was approximately 30 to 40% reduction in A&E visits at the peak. There were also reduced acute coronary syndrome admissions, roughly down to 25 to 40% as per ESC survey, which I'll share in a moment. There was a concern as to where they've gone. Are they avoiding admission, and are they presenting late with a higher mortality? So European Society of Cardiology conducted a survey of a few thousand cardiologists on their panel, and they wanted to know if there was a reduction in presentation of ST elevation MI. And you'll be surprised to know that no matter where they lived across the globe, approximately 75 to 80%, this orange box, felt that there was a significant reduction in the number of acute ST elevation MIs coming to hospital during coronavirus pandemic. People were scared to come in. This was covered in the news, and while not doing so, they actually did more harm. And hence, it was very important, and maybe a take-home message, that we try and reassure our patients that the remaining services in the hospital are still there. And if they do need to seek medical attention, they must do so without the fear of coronavirus. Talking of acute coronary syndrome, briefly, it's difficult to distinguish acute coronary syndrome in COVID-19 because symptoms overlap. Chest pain and breathlessness is common in both. Hence, it's difficult to tell one from the other. But if not treated well, they can lead to cardiogenic shock from a large MI, and these patients may end up in ITU. Distinguishing between the two groups is important though, because the treatment differs. Hence, in the pandemic era, it was recommended that small troponin rises, which is less than 2 times the normal, now depends on what assay your hospital is using, in the absence of typical anginal symptoms should not warrant any investigations. I'll just give you an example. In our hospital, if the normal troponin level is up to 14 or 15, somebody with a bit of breathlessness and troponin of 30, but no significant change in ECG, should not be treated as MI, because in the midst of pandemic, there were a lot of other factors playing their part. So troponin should only be checked if type 1 MI is suspected or there's new LV dysfunction. Having said that, it does not routinely happen. It's one of the tests we do quite often. One thing to remember is myocarditis has gone up in its incidence and prevalence during this era, and that's something to keep in mind. But general advice has been to consider angiography only for moderate to high risk cases and not for mild to moderate, which can just be treated medically. To back it up, European Society of Cardiology has given this flow chart. If you look on the left, are unstable patients, or they should just go straight to have their procedures done. No change in the guidelines. People who are low risk, again, once they've been tested for virus, should go for non-invasive tests. This is what was recommended before. But if in the middle category, the orange and yellow ones, the high-risk patients with ongoing symptoms or ECG changes should still proceed with early invasive strategy within 24 hours. But this is the one which makes difference now. Immediate risk patients, despite the fact that they have diabetes or a bit of heart failure, or even if they've had a little bit of more chest pain after admission, during the pandemic, the decision was to treat them with non-invasive tests rather than invasive tests, because that would expose them and other staff members to COVID. ST elevation MI is obviously another story altogether, and we do not have time to deal with these patients. You really have to get on with it, achieve what we call call to balloon time of 120 minutes, which means when the patient has chest pain to the time we perform angioplasty, it should only be 2 hours gap. We don't know if these patients have COVID or not because they are just coming off the street, so full PPE is required. Just to remember, angiography itself is not an aerosol generating procedure, but if there's a cardiac arrest on the table, then CPR is, and that makes it more confusing. Do remember that COVID myocarditis can mimic ST elevation MI, and we have ourselves seen some cases and also heard from other colleagues about it. At the start, when nobody was sure what was going on, there was even discussion of thrombolysis being brought back in to avoid every patient going to Cath Lab. But we've managed to avoid that, unless in some places. For ST elevation MI, again, take them straight to Cath Lab if it's feasible, thrombolyze them if you can't, but if they present themselves to A&E, try and contact the Cath Lab which is working and take them there. This is just an example of ST elevation MI of a patient we treated in our hospital. And this is a patient who was in the hospital with COVID, without any chest pains to start with, but a few days later developed chest pain and ST elevations in the inferior leads. To remind us, all of you, we've already discussed that COVID is a prothrombogenic process. It causes blood clot formation. So this is the right coronary artery, which was completely blocked with a thrombus sitting here. We managed to open and put a stent in, and this was the clot we aspirated, and it's much bigger and thicker than the clots we usually aspirate, proving the point that COVID does induce thrombogenesis. Heart failure can get worse with COVID, and on the vice versa, COVID can make existing heart failure worse. I won't go into too much details on that. Myocarditis is definitely on the rise. It's an inflammatory process. Troponin levels can be massively elevated. So what I tell people is that if troponins are in the 10s or 15s or 20,000s, extremely high, and patient does not have any territorial ECG change, and it's either widespread or none, then it's more likely to be myocarditis than acute coronary syndrome. Acute coronary syndrome probably has a slightly lower troponin elevation compared to myocarditis. Limited data on how to treat them best, but in recent evidence, there's been a role of steroids coming from recovery trial, which helps in myocarditis. But in our practice, we've also used colchicine, which is a potent anti-inflammatory, and is being used more and more. Personally, we've used it in cases in our hospital with good effect. And now, in the last few weeks, I've seen some more data coming out showing that it reduces arrhythmia in patients with heart failure and ischemic heart disease. So it's a no-brainer these days. Another example of COVID myocarditis, where a patient who was in his 60s had recovered from COVID 2 weeks prior to admission. He was known to have dilated cardiomyopathy with a stable condition for years, but he basically came in with syncope and palpitation. And on a cardiac monitor, we picked up a sustained run of ventricular tachycardia, for which he was treated. We repeated his echocardiogram and noticed that his heart function had dropped from 40% to about 25%. So he was treated for myocarditis, and the presumption was that that myocarditis left a scar on the myocardium, which caused VT. His angiogram was normal, so no intervention was required, but he went home with ICD implanted, and since then has been doing well. Stress-induced cardiomyopathy is worth mentioning because we are going through a stressful phase in our lives. It's a condition, for those who don't know, it's a condition that is transient after a stressful event like trauma, surgery, bereavement, any operation, or even earthquakes and natural disasters, which can cause or mimic acute coronary syndrome. Patients present with chest pain, some ECG changes and troponin rise, but when we do an angiogram, it looks absolutely fine. And within a few months, echo returns back to normal. I have certainly seen 3 cases in the last 4 months, and in all of them, one of the family members had died from COVID, And it was a situation where family members could not attend funeral either. It was extremely stressful for the family members, and they then got admitted with Takotsubo cardiomyopathy. So because it becomes more common after earthquakes and disasters, I won't be surprised if you see more of this around in the next few months. Other issues that affect the heart, dysautonomia. COVID, because it's an endothelial disease, it causes autonomic dysregulation, and neurologists also notice it in the clinics. People present with falls and...
Sakib, sorry, a couple of more minutes, yeah?
Yeah, sure. I've only got a few slides. And QT interval is often asked about. Hydroxychloroquine can prolong QT interval. However, it does not cause arrhythmia unless QT interval is more than 500 milliseconds. So it's not as common as we think. Last few slides, how did we manage to deliver services, or we can continue to do so going ahead? Do remember that the resuscitation guidelines have changed for patients undergoing cardiac CPR. PPE is required. We in our hospital managed to continue inpatient work, but obviously had to filter out some of the outpatient work and only select the semi-urgent cases. Our ward became a COVID ward. We continue to deliver our procedures. The blue lines are intervention procedures and the green ones are pacemakers. None of the work stopped during pandemic, but it was just better case selection. Interestingly, nobody on our ward died during the peak. And that was probably because the worst cases were appropriately triaged to intensive care or respiratory wards. So this is the new normal. We are staying away from each other as much as we can. And this is our Cath Lab recovery area. That's the Cath Lab door. This area should have 6 beds, but we are down to 3. And we have to gown up appropriately, just like firemen do, not knowing what you're dealing with. So in the end, I'll just conclude by saying that cardiac involvement in COVID is a poor prognostic marker. Acute myocarditis is more common than in the past, and it can mimic acute coronary syndrome. Staff safety is paramount without compromising patient care, and we need to get the right balance between emergency routine work. Thank you very much.
Okay, thank you very much, Sakib. I think some really important points actually raised by both of you. So, and it seems just to kind of actually recap and highlight that your cases have actually demonstrated what multidisciplinary meeting, the importance of MDTs are actually learning from mistakes, learning from our cases, and also the most important bit that I can take from your presentation was actually history. History has got the details. So if you focus on the history right, that is actually the most important bit, because you can get your diagnosis right. And obviously, especially with the cocaine case they've actually described. So I'll let you to elaborate on this, but also for Sakib, I think the most important point that I can take, the take-home message from your slides was actually the COVID is here, and COVID does affect the hearts. And, we all do kind of actually, literally flab about COVID and the rise of troponin in these patients, but also that, most of the patients that I know and have worked during the COVID days was, people with heart attacks or chest pains actually ignoring the the pain and not really seeking urgent medical help when they should have really kind of actually done that. And they presented quite late with really worsening heart symptoms and in some cases actually cardiogenic shock. So really powerful messages there, important presentations by both of you. I will now ask Naseem to unmute everyone so that the floor is open to questions. So with no sort of particular order, you can guys ask questions to both Naseem and Sakib. Yeah.
Could I ask Naseem one question before others, if that's
of course.
Very quickly, Naseem. Fantastic talk, Naseem. Lovely cases that you shared with us. Just one question. What is your experience, and how would you say you can reflect on this? Obviously, we thrombolize patients for stroke in the very early hours. But do you think that if they completely recover within 24 hours, can you then say that you actually thrombolize what might have just been a TIA? How do you differentiate them?
Yeah, absolutely. We thrombolize TIAs all the time. Absolutely. We thrombolize TIAs, we thrombolize migraines, we thrombolize seizures. Very difficult to differentiate. I think going back to Mansoor's point about history is vital. I mean, the reason you do CT scans is not to rule in stroke. The reason you do CT scans is to rule out bleed. And that's very, very important. I mean, in some centers in America or regional, tertiary centers, they have CT fusions and look at penumbra and areas, salvageable brain and MR perfusion scans and all that. But in most parts of the UK, especially the telestroke in Lancashire, all you have CT. Maybe the next working day you can do MRI scan and confirm whatever. But history is vital. CT scan is not to rule in stroke, is to rule out bleed. If CT scan is pretty looking okay, and you have history suggestive, you thrombolize, and yes, we think with the TIA, the definition is actually changed some time back. It's not the 24 hours anymore. The TIA is basically there are two types really: TIA with brain reversible ischemic neurological deficit and with ischemic deficit. So actually it's shown that if you have symptoms lasting for more than an hour, and if you do brain scan on those patients, you actually see changes of permanent ischemic damage in those patients. So that the 24-hour definition is actually very old. I would say any patient that has symptoms lasted for more than an hour actually had a small stroke and not a TIA.
Thank you very much for that question and explanation, Naseem. I'll just actually let people to sort of ask questions. Can I just, before asking questions, can I just remind everyone who've not been regular attendees to this talk, could you just please email me your email addresses, the email address in the chat box, so I can send you the certificates, not from the regular attenders, I've got the emails, but those who've actually attended or joined us for the first time. Thank you. Yes, Mashood, you've got a question?
I have a question for Naseem first. Recently, what I noticed, normally we used to do anybody come with like a stroke-like symptoms or something, we initially go with the CT scan of the head to make sure there is no bleed, as you said. But now there is a recent guideline which in my hospital they implemented, and even especially telling all the hospital people, hospitalist doctor, that they initially go with the CT scan, and the next automatic step is do the CT angio of the head to make sure there is no thrombosis in the vessels. So they directly talk with the intervention neurologist to work on that one. I have two patients in last 6 to 8 months that the patient has a CT scan, and then automatically the stroke protocol come into play, and then they says, okay, we automatically need to go to do the CT angio of that one. So I want you to if you
yeah
talk on that one.
Yeah, absolutely. So there's a couple of things. Well, the American hospital is slightly different. Most hospitals have this interventional neuroradiologists and all those facilities available. Now, stroke is a vascular disease, and most of the time it's obstruction in the large vessel, either in the internal carotid or in the ACEI or in the brain. And it is important to look at the arteries. And if you have the facility, yes, I agree with you. I think you do CT brain as well as CT angio. So you make sure there is no bleed, and then the next step is, where is the problem? So what is the problem? And the next is, where is the problem? And then if you have interventional neuroradiologist available, then you consider mechanical thrombectomies and all that. But my advice to all the especially the doctors working in general medical hospitals, remote and rural setting, small hospitals, is do not delay thrombolysis if you are not sure of the time it takes from the patient to reach the interventional neuroradiology setting, or to get the CT angiogram or MR angiogram. The main thing is to thrombolize straight away. That's evidence-based. But if you have somebody on site, then you could consider mechanical thrombectomy and all that. And for that, yes, CT angiogram is very important. Yes.
Okay. Thank you very much. Any other question, guys?
Just one question. So it's not a basic protocol to follow. Means it's depend on your facility.
Yes, absolutely. No, absolutely. And to thrombolize, you don't CT angiogram. To thrombolize, you just need a plain CT brain to rule out bleed, and then you just proceed.
Anyone else?
Hi, can I ask?
Yes, so go ahead.
Right. Can I ask Saqib? It's more of a slightly funny thing that when you talk about that, the people who have had this coronary myopathy following, the shock one, is that the one where we used to have in Pakistani movies that there was a bad news and suddenly the hero's or heroine's mother and father suddenly start having chest pain? Is that what you're talking about?
Might as well be a fascinating question, but yes, I think Well, we fantasize our movies a lot, obviously. So obviously they would exaggerate anything that they can. But yes, if people have underlying angina, stress can provoke it and make it worse. That's different. But if they've never had angina and otherwise they were well, then a really bad news can trigger a heart attack. Yes, keeping the jokes aside, shocking news can provoke Takotsubo cardiomyopathy. And in fact, there are cases where people have not survived it.
So my next add-on is, do we treat them as if they've had a myocardial infarction without going angiogram? I mean, I'm talking about dual antiplatelets and all those things.
Yes, to start with, you would do that because they may present with signs of heart failure or chest pain, mostly chest pain. You would definitely start with acute coronary syndrome because Takotsubo cardiomyopathy is a rule out diagnosis. You have to rule out coronary disease first before you can diagnose Takotsubo. And even then, Takotsubo remains a suspected diagnosis until the heart function has completely returned to normal a few months later. So you can't confirm a diagnosis unless they've had a repeat scan 3 months later. So, but typically what we see is you see subtle ECG changes, troponin elevation, which is not in context or not in context with the clinical picture, but there is an elevation. And then when you do an echo, you notice that the apex of the heart typically is impaired while the bases are spared. So that's where the word Takotsubo comes from. Takotsubo is a Japanese word which they used to, there's this apparatus they used to use to capture fish and octopus, and that's the shape it gets. But then it reverses. So initially you start off by treating for acute coronary syndrome, possibly heart failure, but then you later on stop acute coronary syndrome medications like antiplatelets, but continue with heart failure medications because that allows and speeds up the process of myocardial recovery.
Question for Naseem. Cardiologists, when obviously stroke as well as heart attacks are diseases, but cardiologists, they give a very high dose of statins. They have a 80 milligrams of atorvastatin, which I have not seen stroke physicians use. Because actually the reason behind using higher dose of statins is because they are plaque stabilizing. So doesn't plaque stabilization need to be done in strokes?
Yes, absolutely. We used to use 80 milligram in Scotland where I was trained, and I think maybe to do with the SIGN guidelines, the Scottish Intercollegiate Guidelines Network. So they have 80 milligrams atorvastatin. I used to prescribe it all the time. But I think in England we have nice guidelines, and they recommend 40. You could give 80. I would personally give 80, but in some hospitals they give 40. But you are absolutely right. We used to use it in Scotland all the time, 80 milligrams. Yes.
Can I add something to that, Naseem?
Yeah.
I also assume that I'm not sure about why these guidelines are different, but cardiac patients with heart attacks on average might be slightly younger in age compared to people who are coming in with strokes. Now, you may correct me on that if I'm wrong, but maybe a slight age difference. So if that is the case, then the younger the patient, the more the prognostic value of giving a high dose statin. So maybe 40 is enough for slightly elderly people. Just my thought on that.
Although
I agree.
all the cases Naseem described, most of them were in their 40s and 50s. Pretty young, isn't it?
Yeah, because the reason I selected it because it's a bit unusual cases. Most of the cases that we see are very elderly. The calls that I receive in my stroke on calls, they're very elderly patients. Most of them are 75, 80 plus. The reason I include these young patients because they were a bit unusual. Straightforward stroke patients is usually a patient who is 75, 80 plus, lots of comorbidities, elderly, and multiple comorbidities. Yes, but yeah, the age increases, risk of stroke increases. Yes.
Mansoor, if I just want to add one comment regarding statins and the prognostic implications. Yes, we give 80 milligram in acute coronary syndrome, but not in every case. I personally look at their age, their body size. If they're really thin and lean, then statins will cause myalgia and other problems. These statins, all the data is based on 10-year prognostic benefits. So in a 90-year-old, the 10-year prognostic benefit, no matter what you do, is very little. So you can then, adjust accordingly. In a 60-year-old, 10-year prognosis makes much more sense. So not everyone should have 80 in acute coronary syndrome either. That's my view.
Yeah.
Actually, Saqib, if you remember, there was a paper published in New England Journal of Medicine where they compared 80 milligrams of atorvastatin post-intervention to 80 milligrams of, so 40 milligrams of pravastatin and 80 milligrams of atorvastatin, and that is the basis of giving 80 milligrams of atorvastatin, and that was over 18 months, and that was post-coronary procedure. So actually, it was the drug companies who decided what should be given rather than cardiologists, unless until they were on their payroll.
Yes, I agree with that.
Hello. Yeah, I will have a question for Saqib. Great presentation, both of you. I must say, hello.
Yes,
Yes,
I can
we can
hear
hear
you.
Anila, go
You
ahead.
can hear me.
Anila,
Yeah, okay. Yeah, sorry. So, Saqib, since we're talking about TROP-I levels, when you can suspect an MI, whether it's a type 1 or type 2. So, I'll be talking about patients pertaining to my field being pregnant. And most of the time when they are presenting, or someone presents with a high BMI and having COVID-like symptoms, and we go through a baseline of investigations. And we do get a high TROP-I at that point. So, and a ferritin, which is high as well. I think these two being more marked with a COVID-like etiology rather than others. So, how much of importance, how much of a significance does that stand in the long-term follow-up of a patient? Because initially, when we do a baseline TROP-I, nobody seems to follow it till she really delivers. Because I mean, we are just as much concerned about the fetal outcome as much for the maternal. So should we be doing a regular TROP-I sequence like 6-hourly or 8-hourly? And how much of a role of an echocardiography hold in such patients?
So Anila, thank you for your question. Can I just confirm, are you asking this question in context of the pandemic era or in general? Anila?
COVID-19, yeah.
COVID-19,
I mean,
okay.
it's
Okay.
yeah, these days, since
Yeah,
the
so
COVID started.
that's why the troponins are being tested more, because they get worried about COVID and what the outcomes might be. So the advice or general suggestion would be not to act on troponin levels unless there are ongoing cardiac symptoms to suggest underlying heart problem. So because, as I said earlier, 30% of patients who have COVID can have raised troponin of whatever degree. But unless they've got ongoing cardiac symptoms, there's no need to act on it. And then if you're not acting on it, then there's no need to follow it up either. Coming to the pregnant ladies, obviously they are tachycardic, they have increased myocardial demand. They are sometimes, you can compare them with people who are running and jogging all the time, always pushing their heart, trying to pump more blood out. They may have a slight troponin rise. The ones I will worry about, I've certainly picked up 3 postpartum cardiomyopathy in the last 4 months, where all of them are Afro-Caribbean females who had uncomplicated pregnancy, but within 8 to 10 weeks of pregnancy presented with heart failure symptoms, and they had significantly higher troponin levels, and they had postpartum cardiomyopathy. But during pregnancy or just before, if they're otherwise well, then I wouldn't worry about troponin unless it's extremely high.
Okay, and the role for echocardiography would also be controversial.
So again, controversial. The guidance in the pandemic era is to use as little echo as possible for 2 reasons. One, because which is even irrespective of COVID, is that there's a national shortage of echocardiographers. But more relevant to COVID, you use the same probe and the same machine to go around different wards with different patients. So it actually increases transmission of infection around. So even for angiography and echo, the advice was that whilst patients are having angiography, we should do what we call left ventriculogram to assess LV function rather than waiting for echocardiogram. So use as little echo as possible. I personally use a handheld machine more than the formal machine, so that I can clean it properly and put it back where it belongs, and it's much quicker to use. So we are living in a new era. We don't know what the long-term implications might be.
Yeah, you're correct. I've seen one cardiologist use the same, and what we called it was a bedside echo. So probably that's what exactly was using. Thank you. Thank you very much.
So, Saqib, have you come across a patient who's actually been diagnosed with COVID-19 and had acute coronary syndrome or ST elevation MI, or any form of MI who actually also had positive sort of D-dimers, and they were positive for PE as well, and you had to treat both? Because I had a lot of renal patients actually who had AKI or dialysis patients who needed, who had positive actually CTPA scans. So just your comment on, COVID prothrombotic cases and ACS.
So in my recollection, I can remember one patient who had both, definitely both.
Mm-hmm.
He had a definite myocardial infarction, had PCI, and also definitely had a pulmonary embolism.
Mm-hmm.
But otherwise, there are a lot of patients who come in with chest pain. They end up having CTPA first.
Yes, you're true. Yeah.
CTPA has become, especially out of hours, because there's a lot of, it is teleradiology. No one refuses to do it. Some heart failures are also diagnosed on CTPA these days. So
Yeah.
CTPA then picks up PE first, which then downgrades the potential diagnosis of acute coronary syndrome. So very rarely would you see them both together, but it's not uncommon. It's not impossible. It's a prothrombotic disease. Both can. The case I presented earlier of a patient who had COVID, he was in hospital. He had a small pulmonary embolus anyway. Now, I'm not sure what long-term implications of tiny subsegmental emboli is, but he went on to have a full-blown ST elevation MI.
You're right, because I've had a couple of
Somebody asked me the question. Somebody asked me the question: what would happen? What would you do if a patient has a stroke and a PE and an MI due to COVID? So my answer was, I won't decide then what would be done. COVID will decide what he would do to you.
Yeah,
I'll pray for that.
All right, thank you very much. Thank you, everyone. Actually, we've just gone beyond the time as well. I think I just have to thank Naseem and Saqib for some excellent presentation and generating some really good questions and debate out of this. I think we should really congratulate ourselves. This is actually the highest attending webinar today. So we've had 20 plus sort of attendees from both 2002 and then obviously outside our group as well. Congratulations to all of us, and keep up the good work. And just to let you know, the next webinar is going to be in October, second Sunday in October. I'm just confirming some details with our external speaker, and Naseem will be sending the details very soon. Thank you very much, everyone. Thank you once again.
Thank you, Masood. Thank you, Saqib.
Thank you.
Bye-bye.